I'm Amy Knighton. I am the CEO of Savannah Neurology Specialists in Savannah, Georgia.
What's your practice like there in Savannah?
So we are a private practice, community-based practice. We have 5 physicians currently, one joining next week. We also have 12 advanced practice providers. And we do try to be a very comprehensive model. We have an infusion center, we have an MRI, we have clinical research, we do EEGs, EMGs, so we're a pretty comprehensive neurology practice.
Now I've heard you've been talking at AAN and other venues for years about doing CCM, and I'm curious about that. I'm wondering what you've heard from other neurology groups and why are people not taking advantage of this Medicare program? What's stopping them? What attempts have you made so far, and where are you now?
I became involved in the AAN once I came to neurology. Prior to this, in my previous life, I managed an internal medicine practice for 15 years. And so the chronic care management codes came out when I was managing that practice, and we quickly implemented a program, of course, very manual at that time. And so, I was intimately aware of the codes. And then when I came into the neurology space, I really saw a great use case and need for them. And I think I was met with a little bit of, I think people were scared for a lot of reasons. And again, I got very involved with the AAN when I got into neurology. And so I am on the practice management and technology subcommittee. I'm on the business administrator work group. And so, I really began speaking about what we were doing with chronic care management at Savannah Neurology because we had recently started that program here. And a lot of questions and concerns that people have about it. I would say actually people feel like it's only for primary care and that you have to be managing the entire patient and all their problems to be coordinating their care from a CCM perspective, which I think is a myth. I think people have this thought that so many primary cares are doing it that you're going to be stepping on the toes of potential referral sources. But I think that if you look at the data, though, CCM codes are so underutilized, and that just isn't true. And when people do a little bit of digging in their area and their community, they find that maybe there is an opportunity there. And for me in neurology, I really just found that we really are the quarterback for those MS patients, the dementia patients, whatever it may be. There are a lot of conditions that just lend themselves to a great model being the neurologist being in charge of that care. And so we felt that we were doing a lot of in-between visit work, particularly for infusion patients. And so we started here at Savannah Neurology, we started with our infusion population and our multiple sclerosis patients. And we said, we're on the phone constantly figuring out, did they have their labs? Are they compliant with whatever it may be? Have they had testing? Have they had their MRIs? All of the things that go along with it. And we're spending a tremendous amount of time. And so we began tracking that time. And that's kind of how we started with chronic care management.
Oh, wow. So can you talk to me about your initial CCM program? Because I think you went through some stages there as you rolled it out.
Yes, we definitely have. I think that in my years in internal medicine, we evaluated a lot of potential solutions or providers who promised to come in and help you with CCM. And in my experience, none of the arrangements really gave a lot of value to the patient. I felt that a lot of the models were like health coaching and things like that. And so I just really had this steadfast belief that you had to do it internally. There was only, in order for it to be meaningful, it had to be just this manual process. And, for me, the fact that when we started here, we had one nurse and one medical assistant. And just the fact that they were paying for themselves, I figured that was a success. We had that safety net, but we were putting our patients that needed that extra set of eyes into this program. And we were being compensated for the between visit work for those needy patients, and it was paying for the staff. And so to me, that was a win. I really didn't see a way to scale it without outsourcing it. And I had been down that road and I was not impressed.
So how many patients were covered by your initial program?
Only about 200. But when it came to implementing it in their own centers, it was going to be a lot of effort for, not as much return at that point in time.
And manual, you're talking phone calls, EMR logs. Okay, got it. Traditional model. So how big is your program currently?
Well, now we implemented family in March,
Uh-huh.
and I don't have the exact numbers in front of me, but I think we're somewhere near 1,000
Amazing.
patients, and so that's incredible. It was incredible. It really was, and I truly I find myself all the time saying, "Why didn't I invent this platform?" Because I always said I want to be able to do this internally. I want my staff managed by my physicians managing the patient population, but I just didn't have a way, all the EHR systems, nothing that I had evaluated basically family was everything that if I could have started from scratch and just made what I knew would help me scale it, I would have invented family. Every time that I'm in the program, I'm just annoyed that I didn't invent it because it really is just it takes into account all of the things I would have put in a program if I
Mhm.
would have designed it myself. So
Amazing. Thank you on behalf of our product team. That's
yeah.
really great to hear. So what is this enabling for those almost 1,000 patients and what are you getting from this program for them?
Well, obviously I'm always a skeptic. I have been logging into family daily myself, just making sure that the interactions were meaningful.
Mhm.
And I have just been really pleasantly surprised. I will say that one of the struggles that we have is staffing our call center. And so at
Mhm.
any given time, we probably have a string of patients who've been waiting on the phone 20 minutes to be answered. And unfortunately, when they are finally answered, it's not going to most likely be by someone that can resolve what they're looking for. They're going to have to,
Mhm.
then leave a message for a nurse or whatever. It's just really inefficient. And as
Mhm.
much as we've tried to drive portal utilization to make it more efficient, even that is clunky. When people have to log into a platform and wait to get an email to know if they were notified back, and
Mhm.
it just that really wasn't easing the burden we were looking for. So what this has enabled is that, my gosh, anytime a patient has a thought or a concern, no matter what day or time, they can send that to us. What it also did to me is in the dashboard where you utilize the technology to maybe flag some of the comments that might be a little more time sensitive. That has been great because when you get a lot of responses from a check-in, at least you can prioritize and order them,
Mhm.
and which is a little different than you're a nurse at a phone and you have 25 voicemails.
Right.
You've got to sit down and listen to them all, write them down, play phone tag back and forth.
Mhm.
So, I would just say that the efficiency of that has just been it really has been incredible. The technology inside of family that's used for the check-ins, where it helps you suggest questions that might be applicable to that patient, that has been great. And so, yeah, I mean, I think it's just enabled that ease of communication that we needed and our patients needed.
That's incredible. Thank you. I was wondering if we could dig into some common myths about CCM that we hear from providers generally, but also from a lot of other neurology practices. And the biggest one is that providers think it will be a lot of work for them. Can you talk about the impact of CCM for your providers?
Yes, absolutely. So for me, I think these patients are going to have needs. They're going to call you. All of
Mhm.
that's going to happen regardless. I
Mhm.
think that doing it in an efficient way only adds, it doesn't take
Mhm.
away. And I can tell you that our physician, this is not some platform that you're having your physicians log into.
Mhm.
I don't think they know day in and day out that anything's different,
Mhm.
honestly. So, if anything, it's just bringing information into the chart that they wouldn't have
Mhm.
otherwise had about the patient for their in between visit work, but it's not adding any work to them, I would say.
Are you getting insights from patients that you don't think you would have captured otherwise in a more traditional model?
Absolutely. At this point in time, when patients come in once a couple times a year, they have a 15 or 30-minute slot where they have to convey everything going on in their life to the doctor, make sure they get their medications
Mhm.
refilled, whatever it may be. And so, really having the time to ask these questions, it's just precious time in a visit. And unfortunately, you don't often get the bigger picture. I really think by building out this comprehensive care plan with the CCM team, where you really are looking at those other elements of what goes into a patient's overall health,
Mhm.
what their goals may be. I mean, when's the last time a physician's asked you what your health goals were, or who you went to for support if you needed it in your community, or some of the social determinants and things? There's just not time for that, right? We're making sure your meds are refilled and that you did a lab test, but it's that beyond, that's the total picture. And I think that's, the goal of CCM is actually to improve the outcomes, right? And I do believe all that data collected in between visits helps the physician have a better picture of what's going on with the patient on the whole. And I think that will, in turn provide better health outcomes.
So, all right, another myth that we hear: time tracking and compliance is a pain, and the program is just not worth it. Too much work, not enough value. What's your take on that?
Yeah, I mean, I get it because it can be very manual. And I think people still are hung up on that. I have to be on the phone for 20 minutes and then I have to document this perfectly structured note. And then I have to have a doctor sign it or whatever it may be. There are a lot of myths about the requirements of the program. So I get where people would feel that way. The side that I've always advocated on over the years is that you are doing that work anyway. Those patients are calling you. They need you. You're doing that in between visit care. Why not capture it? But again, it can be that way. It can be very burdensome. And so for my measure of success was just that the program was paying for itself, right? Because it was so burdensome. And now looking back, now that we've implemented family and it is possible to scale in a neurology practice and have a very robust CCM program, now obviously my measure of success has moved, right? It's not the same measure that it was before. Before I was just proud to have that program. And it really was just the safety net in my mind for that population of patients. And I knew the outcomes that were coming out of it. I knew how valued those patients felt, that they had a dedicated care team. I knew that when a patient got in one of our infusion chairs, that they were good to go. They had been screened, monitored, tracked. It wasn't falling through the cracks on it, And so I always knew those things. And so that was success to me. But so what I would tell people is that it is possible to have a program and to not have it be burdensome and to be able to have that for your patients.
So, how do you handle time tracking currently? How does that work for your nurses and your care manager?
Well, within family, it's very nice. So as long as they are in the patient's account in family, it is tracking that time. You also can go say that you're not in family, you're in the EHR and you're working. It's so easy to log that time in family. So much nicer. I mean, prior to this, we were literally documenting in a note that stayed open for the whole month for the patient, all the increments of time that we were doing. Very burdensome and very, it just wasted time, not a good use of a nurse's time and medical assistant's time to be sitting counting minutes all the time. And so now it's basically handled for us, which is so nice. And, prior when we were on a very manual version, at the end of the month, we'd have to try to figure out, okay, who has 16, how many patients are we close to billable minutes, but we're not, and how can we manage that? And within family, that's been made so easily managed within a dashboard where you can see these are my patients that have 15 plus minutes, or these are the people that are at billable events. And it really is just so much easier to manage the population that way.
I'm so glad to hear that. Thank you.
Yeah.
That's wonderful, especially because, another myth we hear is that you have to talk to patients for 20 minutes on the phone each calendar month. And okay, maybe sometimes you have that phone call, but that's not always how it goes. You may be exchanging messages. You might be doing work behind the scenes to coordinate care for that patient. So can you talk a little bit about that common myth of I must call my patient and talk with them for 20 minutes?
Yes, that is such a myth, and you're so spot on. And I often see people who do try to implement these programs on their own. Occasionally, they'll do the 20-minute phone call because they think that is what is required for billing, and then they spend additional time that they're not capturing, actually carrying out whatever came out of the conversation. When actuality, all of that time would be billable. And really, it's the check-in with the patient, but it's the what are you doing to coordinate their care, right? It's chart reviews, it's tracking down notes from other specialties, it's making sure labs are done, it's any paperwork that you're completing for the patient. So it's coordinating all of those clinical activities that count towards that time, and it does not have to be dedicated time talking to a patient. So you're right, that is a very, very common myth.
And as a patient, I might not want to talk to someone for 20 minutes, whether I need to or not, once a month, right? That might not be what's best for me to achieve my health goals.
And that's such a good point. I will say, when we were before family, or when we were very manual, we actually had some patients, in fact, who said, "I just want to be contacted every 3 months or every
Mhm.
6 months," because they just didn't want to sit on, they didn't want us to call them every single month. They knew
Right.
we were there if they needed us, but
Mhm.
we literally had a manual way of tracking people who didn't want to be called every month. And so you're right. I think that 20-minute time commitment on the phone, some people don't
Mhm.
have.
Right.
So yeah.
Or they want, maybe they had their 20-minute call, but then something comes up the next day, right? Do they wait for the next month to have that call? Do they reach out and try to get in touch? So having like a really quick way to check in with your care manager is huge.
Yes, that
Yeah.
absolutely is, because that scenario absolutely happens,
Mhm.
and where you've spent this 20 minutes of a
Mhm.
conversation, but, more time is necessary throughout the month.
Mhm.
Yes.
Yeah.
And
Well,
we
so.
even, I'll say, even in our manual days,
Mhm.
we began scheduling the phone calls because it got so hard to
Mm.
just cold call people. I mean, we
Right.
tried that route, but I mean, people are busy, and so it
Mhm.
really got to the point where we were scheduling the phone calls, and so we actually had a CCM schedule in our electronic medical record that we were calling patients on a certain schedule. And so when it becomes that rigid for a patient that you have
Mhm.
to schedule appointment for a phone call, you're certainly losing the flexibility. And then you have to hope that you think of everything in that 20
Mhm.
minutes, like you said, or it's just too burdensome to get back through. And we thought we did it pretty well. We had
Mhm.
a dedicated phone number. They did not have to call through the call center. We gave them a little black business card that said, you're in the VIP CCM club, basically. So I think we did it as well as we could in a manual
Sure.
world. We always knew that we weren't helping as many patients as we could. And I
Mhm.
couldn't just keep throwing resources at it. It just was clearly, you can't keep throwing people. Clearly the process needed to change to be more efficient.
Well, so looking back on this trajectory for your program, what advice do you have for a practice considering a CCM service line?
I think it is so important. I think patients, I think it's worth taking the time to evaluate whether it's right for your organization. It's not going to be a waste of time. I think anyone that really looks at this will
Mhm.
realize that they're doing a lot of this work anyway, and it needs to be captured and compensated. I don't know any group that doesn't have some team of telephone nurses or someone that's fielding this in between visit work. And that is overhead, and it is expensive. And so I just think that you're doing the work anyway.
Mhm.
And if you can do a better job of it more efficiently and be reimbursed for it, to me, there's just always been one of the few things in healthcare that are just wins. I think it's a
Mhm.
win for the patient. They have I think they have someone quarterbacking their care. They have a efficient way to contact you when they need it. It's a win for the clinic because it offsets some of that overhead. It really allows you to capture that information you wouldn't have otherwise. And I also think it's just a win for the healthcare system in general
Mhm.
because I do believe it improves outcomes. I believe it reduces hospitalizations. I think it reduces adverse events for patients when they're just not sure if they should have called you or what it may be. And truly, that 20-minute hold online
Mhm.
is worth some people not calling when they have a concern. And so, it's one of the few things I've always felt was just a win-win-win with not a lot of downside. So I
Mhm.
would say, I think everyone should be open-minded to just deciding if this is something they could find a way to incorporate into their clinic. The other thing I hear people say is, I can't hire staff just to do that.
Mm.
I need, we didn't hire staff to do that when we
Mhm.
started our chronic care management. We just reallocated how our triage team was working. So, we had the same, how I thought of it was, we have the same number of patients right now. They're just calling into this team of nurses. Well, what if I took one of those nurses and allocated some of her time to this population? And as it grew, obviously patients were moving from that team over to this one nurse, and that other nurses were taking care of less people. And so it just kind of built that way. So
Mhm.
I also would say to people, you're not going to necessarily have to hire a whole team of people.
Mhm.
I would also tell them with family, because it ramps up so quickly, you can do that with the assurance that you're going to be able to cover that staff. Because that's a hesitation for people, is that they're going to have to wait for this program to grow, and it's going to take a while. And I can tell you, I was blown away at the uptake that we had when we sent the invites to patients. And so even if I had hired two people, it wouldn't have been a concern. There was immediate demand for it. and they were busy right away. And we were getting to billable events that was more than covering their salary for the first time. And so with family, even if you did have to hire someone because you didn't have the staff, you would be assured that you wouldn't be in an upside down situation.